Our next speaker is Professor Allen Cheng. Allen is the Professor Director of Infectious Diseases at Monash. He's co-chair of ATAGI. He's the founder and chief investigator of FluCan, which is getting bigger all the time. And Allen was recently acknowledged in the Australia Day Honours, and it was the best acknowledgement of Allen's career, I think. And I'd like to give you a round of applause. So Alan's going to talk to us about new and emerging respiratory viral challenges. Thanks, Alan.
Thanks very much, and thanks Lou for those kind words. It's always a bit intimidating coming after Ian, partly because, especially if I'm talking about influenza, and I never know what he's going to talk about. But I think I'm going to give a slightly different flavour of H5N1 than Ian, who's thankfully covered off a lot of the virological aspects. So I'm going to talk mainly about avian influenza, but also touch on RSV and HMPV. But the history of avian influenza goes right back to almost 2 centuries ago. First isolated in 1902, and but obviously the strain that we've been most worried about, H5N1, was first reported in Hong Kong in 1997. And this was unusual because there was a very, very high case fatality rate. So obviously you're never sure how many people actually, what denominator you're using for that. But there were 18 cases with a third of them dying. They were all avian genes, and there was a lot of control efforts in Hong Kong in the wet markets there. And it did seem to have this tropism for the lower tract. The current strain of concern is this 2344B, emerged in 2020. So it is a lineage of this H5N1 from 1997, but obviously something has changed. And so my very simplistic understanding of the virology is that high path and low path avian influenza obviously refers to its virulence in chickens, not in humans. And it's to do with the degree to which it can replicate in different organs in the chickens. So high path avian influenza can replicate in most chicken organs as opposed to low path, which is mainly respiratory and intestinal organs. So in 2020, this new clade, 2344B, emerged and really rapidly spread from Europe across to North America, first found in the Newfoundland Zoo in Canada, and then into the rest of North America, and then over the subsequent year spread into South America, where there were really quite extensive mortalities in some marine mammalian species. I think it was described that in young elephant seals there was a 90% mortality, which I think is thought to be a near extinction event for some of these species. And then last year it spread to the Antarctic, to the skua birds, and obviously that's surrounding Australia, but we obviously haven't had any incursions into Australia at this stage. So in the US, there's been this divergence between the bovine and poultry strains, so D11 in poultry, B313 in bovine strains, but there has been some crossover from the poultry strains back into cow and to bovine strains in Nevada just in the last couple of weeks. And then obviously a lot of other mammals have been involved, terrestrial mammals, marine mammals with a very high mortality, as I mentioned before, and wild birds. So the transmission pathways between these aren't really clear, but obviously there's quite a lot of mixing. Ian's covered most of this, but since 1997 there's been almost 1,000 cases of H5N1 with quite high mortalities in humans. In 2024 with the 2344B, there were 72 cases, but much fewer mortality. In the US, as Ian mentioned, there's 67 human cases and with 1 death reported and 1 quite severe case reported in Canada as well. In H5, in Australia, we've obviously had the H7 strains, a single case of H5N1, but no 2344B detected at this stage. The US cases were written up, so 46 of those 67 cases were written up in a case series last year. Most of the people involved were quite young, and I think that probably is worth keeping in mind that influenza is generally a mild disease in younger people anyway, and with most of the exposure coming from cows and poultry. Conjunctivitis seemed to be very common in this case series, and a third of patients had only conjunctivitis and no other symptoms. Fever, reasonably common but not universal, and respiratory symptoms in about a third. The duration of illness was 4 days, so probably a little bit milder than seasonal influenza. In those cases with no animal exposure, there were no hospitalisation, and in this series there was no deaths. But subsequently, there have been these cases reported. The case in Louisiana, an elderly man who died, was thought to be exposed to domestic chickens and wild birds. And significantly, the strain is the D11 strain, so not the poultry strain, not the dairy strain. And there were some differences found between the swab taken from the nasopharynx and then the oral swabs. And there were some changes that might have been associated with different receptor binding, which may be more significant. In Canada, the case that was quite severe was a teenager that was admitted to intensive care. Again, D11 strain, so the poultry rather than the bovine strain, and also had the same mutation that had been seen in the US patient. So it's evident that there is this range of clinical severity from conjunctivitis at one end up to severe pneumonitis. The diagnosis would be with routine PCR. I think it is thought that that H5 should be detected by all the assays that are in use. Infection control measures. So the series of national guidelines. The national guidelines say to isolate for 7 days or until symptoms resolve. Obviously, at this stage, human-to-human transmission is thought to be rare, if any at all. And there's advice for people who have infection, obviously, to avoid backyard chickens. And then antivirals should be available for treatment and prophylaxis. In terms of the available vaccines, so there is this distinction between pandemic and pre-pandemic vaccines. So pandemic vaccines are the ones that are off the shelf, ready to go and packaged. The pre-pandemic ones are the ones that are mocked up, and then they could swap in a new strain if that's felt to be required. There are obviously different strains, different types of vaccines. So Securus have both egg-based and cell-based vaccines. There are certainly others around in development. Moderna have an mRNA vaccine. AstraZeneca have a pandemic live attenuated vaccine that's under development. And then the next thing to think about is what strains are in them. So the licenses are often with some of these older strains, so the Vietnam strain or Turkey strain from much before that. But the strain that would be most matched to 2344B would be this Astrakhan strain that is being manufactured in the pandemic vaccines, and there are candidate vaccines maintained for the other avian influenza strains. As far as we're aware, Finland is the only country to deploy vaccine, and that's they offered vaccine to fur farmers, and there was this very complicated rationale relating to the constitutional responsibility to protect a workforce that's engaged in earning a livelihood of their choice. But we understand that very few doses have actually been administered, so I'm not sure if there's going to be any much human data coming out of that. It is worth thinking about other medical countermeasures, so obviously the usual public health measures, awareness and education of people at risk, actually having a surveillance program, and the jurisdictions have stood these up in, particularly in Victoria and New South Wales. And then this also reinforces the need for sort of a One Health approach where human and animal policies are coordinated. There's a recommendation for people to get seasonal influenza vaccine, not because it's thought to be effective against pandemic or H5 avian influenza, but because to try and reduce the risk of reassortment. You can imagine how challenging it must be to wear personal protective equipment in a chicken culling operation or a chicken farm, but that's certainly a recommendation. And then antivirals is something that probably should be thought about in the prophylaxis sense because of it is probably going to be more effective than a vaccine and easier to roll out in some ways. So I guess this does raise the question about, what's different about 2344B, and I guess, we don't know for sure what are the drivers of this, but it is always worth going back to first principles and thinking about this epidemiological triad. So thinking of the host, the environment and the virus. So in the host, there is now quite a broad host range, birds and mammals being involved, both wildlife and food production animals also being involved. The viral tropism with different organs, particularly in chickens, being affected. In terms of the virus, clearly there must be some element of increased transmissibility, and that probably does relate to receptor tropism to some degree. And then I guess of concern, there is this very large biomass which with the potential for mutations to occur. And then in terms of the environment, the food, as Ian mentioned, the food production environment is an intensive environment, and there is obviously a lot of potential of interaction between wildlife and food production, and I guess this is where free-range chickens might be important here. There was an excellent talk from Tis Kuken, I don't know if that's how you say his name, at the Sydney Infectious Diseases Institute last year, and he does make the case that there are root causes to a lot of these problems, and we are exceeding 6 of 9 planetary boundaries, so a lot of this is not probably very sustainable, and a lot of his view is that a lot of this emergence of high-path avian influenza is linked to intensification of poultry production, and there is, I think, 500 million poultry birds in production every year. In terms of the public health response, we now do have a Centre for Disease Control, which is, and it does have funding now. The National Incident Centre has been stood up for this. There is a One Health branch within the CDC and other expert branches. There's a lot of thought going into surveillance, data governance, and then sharing data between jurisdictions and the Commonwealth. And there's an avian influenza response plan has been developed, again led by the animal sector, but with a human component. And it is worth bearing in mind that we do have an Australian Health Management Plan for pandemic influenza that probably does need to be updated. It was last updated before the COVID pandemic. CDNA has had briefings, there's jurisdictional surveillance, there's a series of national guidelines document on the response to avian influenza that covers the management of cases and contacts and so on. And then PHLN have been thinking about testing issues and biosecurity issues and so on. I think someone's going to be talking about the sort of pathogen X approach, but and I think Cantor spoke about this last year actually, but the idea that there's only a finite number of things that probably can cause pandemics, and trying to learn more about viral families that can affect humans, thinking about diagnostics, vaccines and monoclonals and treatments of this. And then obviously there's a major, the implications of the US withdrawal from WHO is obviously an important thing to think about. I'm just going to flip over to RSV, obviously not an emerging pathogen, but something where we have a new vaccine. And this is FluCan data from last year. So just note that the axes on the paediatric and the adult graphs are obviously different, RSV being a predominantly paediatric disease. But you can see that there really is quite a major burden in children, and the slightly darker colour at the bottom is children under the age of 6 months. So considering how small a population group that is, this is really an enormous number of cases there. But what we do have now is nirsevimab, and then this year we will have maternal vaccine. And as most of you probably know, Western Australia and Queensland both had significant nirsevimab programs. New South Wales and some of the other states had much smaller, more targeted programs. So this is the nirsevimab status of controls and cases, and you can see that in controls, which is a reflection of the population coverage, you can see both Queensland and Western Australia had relatively high population coverage. One thing to keep in mind is that the population coverage does reflect the timing of the season, because controls are recruited at the same time as cases. And Queensland had a much earlier season than Western Australia. So in Western Australia, there was much more opportunity for children to have gotten nirsevimab, but certainly the coverage was higher, up to 50% in Western Australia, and up to about 30% in Queensland. You can see that gap between the nirsevimab status of controls and cases, and that reflects how good the product is at preventing RSV. And so just looking at that in figures, so just combining those two jurisdictions, so that there's the estimated effectiveness of nirsevimab was between 75 and 84%, depending on the age group you're looking at, after adjusting for prematurity and the month of receipt, month of presentation. So obviously what's new is RSV vaccines that are coming, so I think there's been a little bit of confusion in the messaging about Abrysvo, or the maternal RSV vaccine. It does say something about 28 to 36 weeks, but what actually is meant by that is after 28 weeks of gestation, mother is eligible for vaccine. But where it's after 36 weeks and there's a planned delivery, so elective caesarean that's within 2 weeks, then it's probably not going to work all that well, and therefore they probably should get nirsevimab if that's available. There's been some concern about the Moderna RSV vaccine, and this was a presentation to VRBPAC last month. There was a safety signal that was detected in the mRNA vaccine for young children, and this was in a very specific cohort. I think it was the Panama cohort, and there did seem to be a higher proportion of cases that was severe as opposed to in the unvaccinated group. They're pretty small numbers at this stage, and they were all in children that didn't have any evidence of prior RSV infection. So this is of obviously some concern, and particularly in the context of the history of RSV vaccines, where inactivated vaccines back in the 60s did seem to increase the severity of RSV. So obviously the trial has been put on hold, and there's a lot of work being done into understanding that better. RSV, and this is a segue into human metapneumovirus, which is actually sort of relatively similar to RSVs in a lot of ways. It just has, RSV has a couple more genes than human metapneumovirus, and obviously is one cause of acute respiratory infections. And like RSV, it is more significant for infants, maybe slightly older infants than for RSV. And it's found in about 8% of acute respiratory tract infections presenting to general practice. So that makes it less common than COVID, influenza and RSV, but still an important pathogen. So we looked at this in our Flucan cohort. So these were just convenient samples. So we capture a group of other vaccines as controls for people that happen to have, or the controls for the cases, which are flu, COVID and RSV. So these are not any systematic sampling. These are just ones that we happen to have picked up, and there probably is an oversampling of paediatric cases. So we found 246 cases in the database from last year, 40% of them being under 5 years of age, and quite a significant proportion of children having chronic comorbidities, and of the cases in the elderly, a very high proportion that had comorbidities. And the proportion going to intensive care, just again remembering these are not selected cases, was about 8%, which is quite similar to COVID, influenza and RSV. So just looking at the age distribution, so the left is the full age range. You can see that children dominate that, and if you break down the children into smaller age groups, you can see again it's children under the age of 1, or with a small proportion, small but significant proportion going to intensive care. And then in older adults, again, the axis is less, but and obviously the population group is much bigger than the single age groups below the age of 5, but a significant burden in that group. So to conclude, H5N1 avian influenza is probably going to come to Australia someday. Every other continent in the world has it. And it's terrible for chickens, terrible for birds. It would be assessed as probably low risk for humans at this stage, but obviously things are changing fairly quickly. There are a lot of preparedness activities going on, surveillance of agriculture. Wildlife Australia have a program. There's a lot of thinking about One Health response plans. And then just thinking of other respiratory viruses in humans, RSV does look pretty good. The adult vaccine does look effective, but the paediatric vaccine does look like it needs further work. And then HPMV does seem to have a fairly similar epidemiology to RSV. I guess one question that I'm constantly asked is, how worried should you be of bird flu? And this is from the New York Times, I think about the middle of last year. And you can see the top question is, are you a public health official? In which case you should worry. And then are you an agriculture official? If you are, you should worry. If not, then don't eat raw milk of chickens, I think is the summary of that. And I think this is probably still fairly good assessment of the situation here. And I guess just leaving you on there is this alert on the CDC website to say that the CDC's website is being modified to comply with President Trump's executive orders, and I think there is probably going to be quite extensive impacts of this, which are yet to play out, and something we all should be very concerned about. So I'm happy to leave it there, and happy to take questions.
Alan, thank you. There's an online question. Was there any pushback from parents about giving the Severnamere to infants?
I understand not. I don't know if there's any paediatricians here. Peter Richmond might be able to answer it, but I understand it's been pretty well accepted, and that distinction between vaccines and immunisation hasn't been quite so prominent.
Absolutely. So really very high take-up, very not really seen as a different. Not really seen as a different product. The only discussion point is that you're protected as soon as you've got it. So I think parents felt that was an advantage. But yeah.
I think maybe that's why you've got the microphone. I understand that, it's almost like a vitamin K model. That all infants get vitamin K at birth. They get nirsevimab at birth, and that sort of makes it fairly uncontroversial and just something that's done at birth. But I'm just wondering, with the maternal vaccine, is that going to confuse? Going to make it much more difficult.
Yes, you've stolen the thunder from my talk.
Oh, I'm sorry.
but no, look, I think this is a real issue as we try to get our heads around having a combined maternal vaccine and monoclonal antibody. How do we approach families with this? And I think that's a good question. So I think it's going to be interesting times, and I think Australia will hopefully be able to solve those quandaries.
Yep.
Okay. Kirsty and then John.
So this follows on really nicely. Is there any benefit to maternal vaccination at the right time point plus Beyfortus for the child at birth?
I think that the main issue would be cost effectiveness. They're both relatively expensive, and so the incremental benefit of nirsevimab over in an infant whose mother's been vaccinated is probably small. There is a recommendation that very high risk, and this is the group that used to get palivizumab, would get both. But I think the cost effectiveness in other groups would probably be fairly low. I think the protection is sort of 80% or so. So it's a pretty strong vaccine, pretty good vaccine.
John Litt.
Two very quick RSV questions. Will vaccinating the kids, sort of in the first 1 or 2 years of life, just push the morbidity window out to an older age? And the second question is there any evidence that if we actually get good levels of coverage in children, that we might get a herd effect like we saw with pneumococcal vaccine in older people? Given that we don't have an NIP-funded RSV vaccine for older people.
Yeah, so to answer the second question first, I don't think so. I think it's just far too small a population group to have any sort of significant population effects. But there is quite intense transmission in children, so maybe there might be a little bit. I think when in Spain and places where they've rolled it out, they've basically found no impact on 1 to 2 year olds compared to under 6 months or under 1 year of age. So that would also suggest that there's probably not, and they had very high population coverage, so that probably isn't any herd protection effects. And then in terms of the second year of life, I mean, I do think it is a little bit, it is like getting your first RSV vaccine. It's your first exposure to, first RSV infection. And so it's probably not unlike rotavirus, where you're trying to give someone a milder exposure, and then the second time they see it, it's not quite as severe. And also like rotavirus, it's a less severe disease the older you get. So if they get it in their second year of life, even if there's just because of their age, they'd be less susceptible from severe disease.
2 quick ones here.
Thanks, Alan. Also for Ian, one of the issues about H5N1 in cattle in the USA is the low number of human infections that have been reported by PCR and the generally mild disease. But some of the early sero-survey data in workers in those environments, noting the complexity of the work environment and the multiple places people work and their legal status and so on, would suggest that the infection rates are actually higher and that there may be, 5-6% of workers who are seropositive. So it's an ongoing issue.
I think it's one of those sort of epidemiological features where it always looks more severe when you start. So the fact that it started off looking not very severe probably means that it is probably a fairly mild disease, I think. Helen?
To the discussion around RSV and around maternal immunisation, we've just published a paper. It was with quite a few women, though, in focus groups, whose preference really is to take the needle for themselves rather than, their baby having a needle in the first few days. It's small numbers, but I just think it's important information. And I know from Queensland that it was a bit more difficult for them because parents really sort of queried this 3 needles at birth, having Hep B, vitamin K. So I think, there's obviously pros and cons against both. It is much harder, I think, for Western Australia, having already got a program in place. But I think for the maternal uptake, hopefully we can be optimistic.
I think Margie Danchen's also done a bit of work in that, and I think, as I understand, she's found some work to say that, or some findings to say that choice is important.
Third last question, Alan, and then Tom.
Alan, HMPV length of stay in hospitals, you had a look at that. Is there anything different from RSV or from influenza, or is it a couple of days or longer?
Good question. I haven't looked at that. It is always confounded by age, but I don't remember that data off the top of my head, but I'll take that on notice.
Ian?
Oh, sorry, Alan.
Alan, this reflects, I think, on what Ian was talking about as well, with the pathogenicity of the current H5N1, particularly in the USA. And you mentioned that a lot of these infections were conjunctival infections. You also mentioned some changes in receptor specificity. I'm just wondering whether either you or Ian would like to comment on whether the virus has now got a greater affinity for the conjunctiva than for the respiratory tract.
Might have to let Ian take that one. I do understand that there are differences between upper and lower tract sialic acid receptors, but I actually don't know what the conjunctival receptors are.
Yeah, so there's two, alpha-2,3 and alpha-2,6 in the eye. We know that the eye is a source of infection. H7's infections preferred route is through the eye. This one is, but I think that's more just environmental, splashes, etc., from the milk going all around the dairy more than anything else. Less likely to be inhaling it.
Last question, Tom.
Thanks, Lou, and thanks, Alan, again for a great talk. What can you tell us about nirsevimab in immunocompromised hosts? Have we been using it? How effective is it? And I suppose also with the human metapneumovirus infections in the children that was more severe and therefore hospitalised, you mentioned comorbidities were a big factor, and I know it's probably a selected cohort, but how often were there two viruses, so a rhinovirus, something else, or couldn't we tell?
It's a good question. I don't know the data from off the top of my head, but I do understand that there's a lot of co-infection, particularly in children, and it's always hard to know, are they sequential infections and then you're just detecting, the DNA or the RNA from a previous infection. In terms of nirsevimab in immunocompromised, I have asked about that, and in the context of, obviously the dose for neonates is pretty small, and there's a very acute shortage of nirsevimab. So the adult dose would be like grams of it, and I think there's not much appetite to use all of our supply on one adult, essentially. So I think it's an area of study, and I think, as the new antibodies come on, it would be something that we should look at. But I think we need to get through this acute stage first, but it should work, I guess.
Alan, thank you. Terrific talk. It's time for entree, and then we'll start again in 10 minutes. Thank you.
Thank you.